Hello and welcome to another segment in the RAD Foundation's Snapshots of Success series. These videos provide insight from asthma experts across the United States about how national asthma guidelines can be used in daily clinical practice. For more information and a full CME accredited activity, visit us at www.rad-foundation.org. This activity is sponsored by the Respiratory and Allergic Disease Foundation and the Postgraduate Institute for Medicine. It was made possible through an educational grant from Genentech Novartis. The NAEPP developed 6 priority messages from its most recent asthma guidelines. One of these focuses on allergen and irritant exposure control. The Guidelines Implementation Panel states that clinicians should review exposure to allergens and irritants and provide strategies for reducing the impact of these when a patient is found to have a sensitivity. This is Dr. Thomas B. Casale discussing the clinical basis for this priority message.
Hi, my name is Tom Casale, and I'm the Vice President of the Respiratory and Allergic Diseases Foundation. Today I'd like to discuss an important issue, and that's a EPR3 priority message concerning allergen and irritant exposure and the practical implications for the treatment of patients with asthma. Now, why is this important? Well, it's important for a number of different reasons. Because we know that allergy is such an important trigger for asthma, as can some irritants be, we need to, as clinicians and healthcare providers, assess our patients for any particular triggers such as these that could either exacerbate their asthma to the point of an emergency room visit or just make them chronically harder to control. So the first thing that you have to do is determine a patient's exposure to allergens, especially indoor inhalant allergens. Although patients are exposed to a lot of pollens, they don't tend to be as significant in inducing asthma symptoms as do the chronic indoor inhalants such as cat dander, indoor molds, and cockroaches. The next step is to assess the severity or sensitivity to the allergens to which the patient is exposed. And that's done by a patient medical history and correlating that history with some sort of objective measure, either a skin test or an in vitro test, to make sure that that patient actually has antigen-specific IgE antibodies to the substances that they're exposed to, and to correlate that with positive symptoms. Now, as I mentioned before, allergy is the very important trigger for asthma, and in fact it's the 5th leading chronic disease in the U.S. among all ages. The worldwide incidence of atopic diseases has more than doubled in the past 2 decades. And if you look at the 23 million Americans that have asthma, a large percentage of them are atopic. In children, that could be as high as 80 to 90%. In adults, approximately 50 to 60%. So it's extremely important to recognize this as a precipitating factor for asthma. To objectively define which allergens that a patient is sensitive to, you need to do multiple analyses. First, you have to step back and confirm the history in regards to exposure and positive symptoms. And it's important to talk to your patients so that they understand and accept their asthma, and then you could provide guidance for self-management activities, which include avoidance of particular allergens or triggers that make their asthma worse. In addition, this will help select more targeted therapies to achieve better control. And then finally, because of newer data, we know that patients who are atopic may be eligible for an anti-IgE monoclonal antibody such as omalizumab if they have significant disease or allergen immunotherapy, which addresses the allergen-specific triggers for an individual patient. I think one of the best illustrations of the relationship between asthma and atopy in general was published in 1989 in a study by Ben Burrows in the New England Journal of Medicine, where he showed a very nice positive correlation between the odds ratio for the presence of asthma and increasing serum IgE levels. And what was interesting is that this correlation held up regardless of whether the patients had asthma or airway hyperresponsiveness, so that serum IgE levels were related to both, and both of these, asthma and airway hyperresponsiveness, correlated with serum IgE levels even in patients that did not have a good history of allergy. Now, how can that be? Well, we know that IgE has a number of biologic effects that could predispose one towards underlying inflammation. Furthermore, we now know that local IgE production in the respiratory tract could be important, so that patients may even have a negative skin test or negative RAS test for allergen-specific IgE, but they're making IgE locally to a particular allergen that could trigger their symptoms. Another issue is, well, okay, I have a patient that I think has atopic predisposition for their asthma. How do I really confirm this? Which objective test do I do? Do I do a skin test? Do I do an in vitro high-quality test? Well, there's pros and cons of both. The skin testing has a higher sensitivity and is a very good way to diagnose allergy quickly. You put the allergen on, patients react to it within 15 or 20 minutes, and you have your answers. The other positive thing about that is that patients could relate to them. If you show a patient that they have a positive skin test to a cat, and they see that large wheal and flare formation, they're more likely to understand that the cat that they own could be a major trigger for their asthma. Over the last 10 years or so, the laboratory methods for doing allergen-specific IgE have improved dramatically, so that one can get fairly good measures of a number of allergen-specific IgE measures. So what do you do with this when you get this? That's one of the problems that some people have to deal with. Depending upon who does the test, what type of test, the numbers may mean different things.
Please see Part 2 of this module for the conclusion of Dr. Casale's presentation.